Medicine. Today our chief discussant for this scenario is Dr. Vikram Damaraju sir, who is Assistant Professor of Department of Pulmonary Medicine from AIMS Mangalgiri. And today the subject moderator is Dr. Bhanureka Madam, who is HOD of Pulmonary Medicine. And the presenter is Dr. Vaishnavi, the third year postgraduate from the Department of Pulmonary Medicine. I request Dr. Monica to come and introduce our chief discussant.
Good afternoon all. Now I take the privilege to introduce today's chief discussant, Dr. Vikram Damaraj Garu, who is currently working as Assistant Professor, Department of Pulmonary Medicine, All India Institute of Medical Sciences, Mangalgiri. He completed his MBBS from Guntur Medical College, Andhra Pradesh. He pursued his MD Internal Medicine and also DM in Pulmonary and Critical Care Medicine from PGI Chandigarh. He is a respected member of several prestigious national and international medical societies like International Association for the Study of Lung Cancer, Asia Pacific Society of Respirology, European Respiratory Society, American Society of Clinical Oncology. He is also a life member of Indian Chest Society and Indian Society for the Study of Lung Cancer. His notable achievements are received gold medal during MBBS in Biochemistry, Pathology and Pharmacology. He also received sponsorship award in ERS Congress 2024 at Vienna and Educational Award in APSR Congress in Hong Kong. He has participated in Anusandhan Divas conducted at AIMS Mangalgiri and won various prizes for his research publications. He also delivered several oral presentations on topics related to pulmonary TB, primary ciliary dyskinesia, lung cancer screening in national and international conferences. He has various publications in prestigious national and international journals. He is also an author of many chapters like Goals of Oxygen Therapy in the Manual of Oxygen Therapy, ARDS and Pregnancy, an Update in Obs and Gynec, Lung Cancer Screening, an Indian Perspective in Zinthal Textbook of Pulmonary Medicine and Critical Care, and many more like this. He is also a reviewer for prestigious journals like Lung India, British Medical Journal, Current Pulmonology Reports, and Monaldi Archives of Chest Diseases. He was invited as a guest speaker and delivered talks in around 20 national conferences and CMEs. His special areas of interest lies in interstitial lung disease, interventional pulmonology, fungal pneumonias, critical care, systematic review and meta-analysis. Thank you. Once again, we warmly welcome you, sir, for today's CPC on behalf of Pulmonary Medicine Department, Dr.Pinnamaneni SIMS Institute. Thank you.
A 34-year-old man, resident of Veeravalli, auto driver by occupation, came with complaints of dry cough since 2 months, associated with sputum since 2 days, breathlessness and fever since 2 days. History of present illness, dry cough on and off since 2 months, insidious onset, not progressive, no postural or diurnal variation, relieved on taking medication, associated with scanty mucoid expectoration since 2 days. Breathlessness since 2 days, grade 1 to 2 according to MMRC classification. Insidious onset, gradually progressive, no aggravating, no relieving factors, no postural or diurnal variations, not associated with wheeze, orthopnea or PND. Complaint of fever since 2 days, low grade, intermittent, associated with chills, not associated with rigors or evening rise of temperature, relieved on medication, not associated with headache, rash, burning micturition, vomitings and loose stools. No complaint of chest pain, hemoptysis, loss of appetite or weight loss, trauma. Past history, no history of similar complaints in the past or allergic manifestations to cold exposure. Not a known case of diabetic hypertension, CKD, COVID, PTB, hypothyroidism, CAD, CVA. 2 doses of COVID-19 vaccination taken. Personal history, takes mixed diet. No loss of appetite and weight. Sleep, bowel and bladder habits are normal. Non-smoker since 18 years, 20 cigarettes per day. Non-alcoholic. Family history. No asthmatic history for parents or siblings. Patient is conscious, coherent, cooperative. No pallor, icterus, cyanosis, clumping, lymphadenopathy, pedal edema. Height is 170 centimeters. Weight is 79 kg. BMI is 28. Vitals. Temperature is 98.6 Fahrenheit. Pulse rate 89 beats per minute. Respiratory rate 22 cycles per minute. BP is 110/70 mm of Hg in right arm supine position. Saturation is 96 roomate. Upper respiratory tract, nose, left TNS, no polyps, oral cavity, nicotine staining is seen. Lower respiratory tract on inspection, shape of the chest is elliptical, trachea appears to be deviated to left side, chest wall movements appears to be decreased on all left-sided areas, apex pit is not visible, no visible or engorged veins, scars or sinuses. Palpation, all inspectory findings are confirmed, no local rise of temperature or tenderness, trachea deviated towards left side, chest wall movements decreased in all areas on the left side except the apex. Apex pit felt in left fifth intercostal space on the mid-clavicular line. Vocal fremitus decreased in left infraclavicular line. Mammary area, axillary area, infraaxillary area, suprascapular area, upper interscapular area, lower interscapular area and infrascapular area. No intercostal narrowing and tenderness. Measurements. Total chest circumference is 99 centimeters. On deep inspiration, it is 1 or 2 centimeters. 3 centimeters of expansion. Right hemithorax is 50 centimeters. On expansion, it is 52 centimeters. 2 centimeters of expansion. Left hemithorax is 49 centimeters. On deep inspiration, 50 centimeters. 1 centimeter of expansion. AB diameter is 26 centimeters. Transverse diameter is 32 centimeters. Spinocapular distance, right is 7 centimeters. Left is 6 centimeters. On percussion, direct percussion, right clavicle resonant, left clavicle resonant, sternum upper 2/3 is resonant and lower 1/3 is dull. On indirect percussion, right-sided areas are resonant, left-sided supraclavicular area is resonant, and impaired note is elicited in infraclavicular and suprascapular area. Dull note is elicited in mammary area, axillary, upper interscapular, lower interscapular, infrascapular areas. Right heart border corresponds to right sternal border. Left heart border corresponds to apex pit. Liver dullness is elicited in right sixth intercostal space in mid-clavicular line. Tidal percussion elicited in right seventh intercostal space in mid-clavicular line. On auscultation, on right side normal vesicular breath sounds are heard. On left side decreased breath sounds are heard in left infraclavicular area and suprascapular area. Absent breath sounds are heard in mammary area, axillary, infraaxillary, upper interscapular, lower interscapular area, infrascapular area. Decreased vocal resonance in same areas on the left side, no added sounds. Other systemic examination, serious S1, S2 hurt, CNS, no focal neurological deficit, per abdomen soft non-tender.
Thank you for giving me this opportunity. Before going, I'll just have a small discussion for the students. How to break down this case based on the history. So this is how we usually have the respiratory symptoms. The main cough, expectation hemoptysis, wheezing, breathlessness and chest pain, and hoarseness of voice and stridor. And we localize these symptoms to either of the 5 compartments, which are primarily airway, parenchyma, pleura or the chest wall, mediastinum and the vascular. And so whatever the symptoms patient gives us, we have to try to localize to either of these compartments. And we have a set of major diseases pertaining to each compartment, predominantly the airway or the routine asthma, COPD, bronchiectasis, and sometimes rarely we also see bronchiolitis and endobronchial obstructions or foreign bodies. Parenchyma is usually the pneumonias and the lung abscess and the cavities and the ILDs, rarely METs and malignancies. In the pleural cavity or chest wall, we usually see the pleural effusions and pneumothorax and mesotheliomas. In the mediastinum and vascular, diseases are relatively rare. In the vascular, we usually see VT, pulmonary hypertension. In the rarer diseases are vasculitis, pulmonary AV malformations, and pulmonary arterial sarcomas or something like that. So these usually we eventually land up in either of these possibilities. So for the set of symptoms that we have, the common symptoms for if we have a airway disease or a symptoms fitting into the airway disease, some of the common symptoms are cough, expectoration, breathlessness and wheezing. Sometimes there is an endobronchial growth or a neovascularization, or sometimes in the bronchiectasis patients we usually have some hemoptysis. And if there is a significant airway narrowing, there can be a stridor also. So the symptoms which are not common to airway compartment are the chest pain. because there are no pain receptors in the airway as such. And in the parenchyma, the common symptoms that we see are cough, expectoration, if there is a pneumonia or the lung abscess, and hemoptysis. Predominantly, the ILDs can have a dry cough, and chest pain can be seen if there is a subpleural consolidation affecting the pleura also. And malignancies and meds can also have cough and hemoptysis. Rarely, primarily parenchymal involvement will unlikely to have a hoarseness of voice and stridor. So, in the pleura and chest wall, the common symptoms patients usually present with dry cough, chest pain, and breathlessness. For symptoms like hoarseness of voice, stridor, expectoration, chest hemoptysis, these are unlikely for a patient who is only having a chest wall disorder. And the mediastinum, there can be a mediastinal mass or a cyst, either in antemediastinum middle or a posterior mediastinum, and can sometimes be a mediastinum secondary to esophageal infections or Ludwig's angina, or sometimes can still be a infective component. And the usual symptoms primarily arise from the mediastinal disorder in such a way that it either can compress the airways or the vascular structures or the neurological or the nerves. So if it's in the antemediastinum, it can compress the airways and cause orthopnea. If it is in the middle mediastinum, it can compress the vascular structures or the trachea, causing stridor or hoarseness of voice. And sometimes they can invade the airway inside. That's when two compartments come out. And so usually and the posterior mediastinal mass can usually present with a dysphagia, and unless until it extends into the airway, it can sometimes cause a cough and expectoration. So usually the predominant cluster do not usually have an expectation hemoptysis. And the vascular compartment usually presents with chest pain, dyspnea, and segmental PTs can sometimes have some cough and expectoration. And the usual symptoms which are not commonly seen are hoarseness of voice and stridor. Sometimes vasculitis can still have hemoptysis, PT can still have hemoptysis, AV malformation can still have hemoptysis. So now that we usually do not deal only with one compartment, and sometimes patients come with multiple symptoms, we have to fit into either of the compartments. Some infections like commonly TB, which can have parenchymal involvement usually, but can sometimes we have airway involvement in form of endobronchial TB or endobronchial stenosis. And sometimes we usually see effusions and also lymph nodes. And mycosis and fungal pneumonitis can still have a airway involvement also. And CTDs, we know that they cause ILDs, but sometimes rheumatoid arthritis can still have bronchiectasis and upper airway involvement, and also can cause effusions, and sometimes cystic can primarily involve pulmonary vessels and cause pulmonary hypertension. And sarcoidosis can primarily involve parenchyma, though airway involvement is not seen in the in the CTs. Sometimes in the bronchoscopy we can still see some nodules or edema involving the airway. And in the form of mediastinum, usually there is bilateral hilar and mediastinal nodes, and rarely sarcoidosis can still have effusions. And the sarcoid himself can cause pulmonary hypertension, which is called sarcoid-associated pulmonary hypertension. Malignancies, if it is can have any compartmental involvement, they can have a mass in the lung, encroaching the airway, going to the infiltrating mediastinum, causing pleural effusion, causing chest wall infiltration, bone meds, and also can have VT. So, coming to these symptoms and the clusters, we will try to dissect what this patient is having. So, in the symptoms, the patient predominantly has something going on for the last 2 months, and on the top of it, he has developed some worsening in the last 2 days. And we'll see what is going on in the examination and in the imaging. So for the dry cough in a 34-year-old gentleman for the last 2 months, so my first possibilities would be the parenchymal involvement followed by a pleural or chest wall and the airway. Mediastinum and vascular, very unlikely to have first symptom as a dry cough. In the parenchyma, I will be discussing one by one in the next few slides. In the parenchyma, the first possibility that I will be having in this kind of a patient who is having 2 months history of cough, many ILDs can come up in the third and fourth decade. If you see the ILD registries, the common ILDs are hypersensitive pneumonitis, sarcoidosis, CTD ILDs, and IPF. But IPF is a fifth or sixth decade. We commonly see in the fifth and sixth decades. and sometimes orthopedic pneumonia and familial pulmonary fibrosis where there is a family history, and some smoking-related ILDs can also be present in this way. And in the parenchyma, you can also have a lung carcinoma, metastasis, and sometimes meds from other areas and other sites can still have a dry cough, and very rarely or very least possibility would still be a pneumonia. So first possibility would be a hypersensitive pneumonitis, which is usually caused by an external antigen exposure. But though this patient usually did not give us a history of exposure, because it can still cause dry cough, and most common ILD in the ILD registry of India is HP. And because of this 2 months history, I would go for a non-fibrotic HP as per, because HP has previously it has acute, subacute, and chronic presentations. This comes under subacute kind of a presentation. Though this labeling has been changed now to non-fibrotic HPs. And the other ILDs are the sarcoidosis. Prominently, I would expect a parenchymal involvement, and some, because usually without mediastinal involvement, without lymph node involvement, it is very unlikely to have a sarcoidosis. And the factors against sarcoidosis are that this patient doesn't have any constant symptoms, or other extrapulmonary symptoms like eye uveitis or parotid involvement or arthritis, and kidney involvement or cardiac symptoms. These are the features which favor against sarcoidosis, but still can be a possibility, because 2nd to 4th decade is where sarcoidosis is common, and in the 6th to 8th decade is another decade where the sarcoidosis presents. And the other possibilities are the CTD ILDs, connective tissue related ILDs. Though CTDs usually have extrapulmonary manifestations, sometimes CTDs can still present with, can start with pulmonary manifestations in the form of dry cough and dyspnea. And the common ILDs which have this kind of initial lung presentations are the myositis-associated ILDs like antisynthetase syndrome, dermatomyositis, and polymyositis. Other than that, rheumatoid arthritis and systemic sclerosis can still have a ILD picture. And rarely NCTDs, IPAF, and undifferent CTDs can still be a possibility in this young male. Though female gender is predisposed to ILDs, but because he's a young adult, I'm still considering a CTD ILD. And he is a smoker with smoking of 360. I should still consider possibility of smoking-related ILDs in the form of respiratory bronchiolitis ILD or a desquamative interstitial pneumonia. Though they have an acute picture, and respiratory bronchiolitis usually is a self-resolving or self-limiting when the patient stops smoking, and DIP is kind of a acute picture when patients land up usually in respiratory failure. These are the features which are against RBLD and DIP. And PLCH is one possibility which is commonly seen in smokers. The only odd point would be the patient usually has a chronic symptoms. A case of PLCH will usually have a chronic symptoms. But this patient has come up in a subacute state. And the other parenchymal ILDs which are not considering are the familial pulmonary fibrosis. Though FPF presents in 3rd to 4th decades, this patient doesn't have a family history, but however, still smoking can rapidly progress a disease. So that is why FPF is very lower down. And some IIPs like IPF and SIP, they usually have a very chronic history. Patient usually present with more than 1 year history, and usually have a 3 to 5 year survival. And pneumoconiosis is also another another common ILD, but not considered in this patient because of no significant exposure. And AIP is one which is not being considered because it has a very acute presentation and has a rapid progression, and usually is a post-mortem diagnosis. And another involvement in the parenchyma we are thinking is a possibility of malignancy. Young male with smoking index of 360, these days mutation-driven malignancies are more common, though females are more predilected for mutation-driven malignancies. Young males are still developing malignancies these days. And more commonly or more frequently, we are seeing adenocarcinomas and more than squamous cell carcinomas. The only points against no constant symptoms like loss of weight and appetite, and no other extrapulmonary manifestations also. Though because he's a smoker, I have to consider other smoking-related malignancies like head and neck cancer, oral cavity or esophageal cancer, bladder cancer, and pancreatic cancer. Though these are the possibilities that come, I am considering, but these are less likely possibilities because of the lack of constant symptoms or the other primary site manifestations. And rarely, very unlikely, tuberculosis can still be a possibility. In the form of miliary TB can still have only a dry cough picture however there are no constant symptoms, and other unlikely organisms are the NTM, nocardia, actinomycosis and fungal pneumonias. Though this patient doesn't have any extrapulmonary though this patient doesn't have any risk factors, like he is not an immunocompromised or uncontrolled diabetic patient who has undergone organ transplantation. These are all very pneumonia is unlikely. So pleural effusion or chest wall involvement can still be considered because of just the dry cough symptom, but there is no chest pain, there is no constant symptoms. That is why pleural or chest wall involvement is still considered, but it is a lower possibility. TB and malignancy, predominantly pleural malignancies can present in the form of dry cough, and very unlikely parapneumonic effusion because the patient doesn't give any history of any fever or consolidation, a fever or antibiotic use, and the other reason, other possibilities of transitory effusion like congestive heart failure or a CLD or a nephrotic syndrome are also unlikely because there are no other symptoms of orthopnea, END and anasarca. So the other pleural disorders like pneumothorax and lymphedema we are not considering because there is no chest pain and dyspnea. And the other compartment I am trying to look at is endobronchial growth or obstruction in the airway. They usually can present with dry cough. The only possibility is because of smoking this, I am considering this bronchogenic carcinoma. And rarely some malignancies like renal and thyroid can still have endobronchial mets. And very rarely sarcoma or lymphomas can still have endobronchial involvement. But the only the points or against are the lack of constant symptoms or lack of hemoptysis, B's and side effect going on for the last 2 months. Benign growths can still be considered because this patient doesn't have any extrapulmonary symptoms, and these benign growths are usually indolent and they do not have any extrapulmonary involvement. These can still be considered, but on the lower side. As discussed, endobronchial TB and mucor can still be a possibility, but the risk factors are less. And infiltrative disorders, just for the sake of discussion, amyloidosis can still have a airway involvement or a parenchymal involvement. It is an infiltrative disorder. Secondary amyloidosis can still be a very less likely possibility. So the other compartments which I am not thinking of is the mediastinum and the vascular. In the mediastinum, there is no compressive symptoms to suggest anterior middle of the posterior mediastinal disease. And also because this patient doesn't have any dyspnea or chest pain, possibility of vascular involvement is also unlikely. So for the last 2 days, he presented with fever, scanty mucoid expectoration and breathlessness. This is what has brought the patient to the hospital, and these symptoms probably suggest some parenchymal involvement in the form of a pneumonia or a secondary bacterial infection. Or if there is an underlying ILD or hypersensitive pneumonitis, you must have had an exposure unknowingly or knowingly and can present still with ILD exacerbation, or it can just be some acute bronchitis or a viral infection. And if we are thinking of malignancies, we can still have a possibility of a PTE presenting with fever, breathlessness and expectoration, but not a massive PTE, just a segmental PTE. So these are what I am considering in the pneumonia for the recent worsening. Can still be typical or atypical pneumonias, and other possibility for the pneumonias, there is a endobronchial obstruction if it is gradually worsening, if there is a right main bronchus or a left main bronchus growth or a tracheal growth, and one of the bronchi can fully be occluded and cause a post-obstructive pneumonitis, which still can present with the fever, expectoration and dyspnea. And as discussed, hypersensitive pneumonitis, repeated exposure can still have fever, expectoration and dyspnea, and CTD ILDs are known to cause exacerbations. So, airway acute bronchitis because of some viral organism can still be possibility for recent worsening. And because there is no history of any underlying asthma or COPD or tuberculosis associated OAD, the underlying OAD exacerbations are unlikely. The PT, as discussed, you know that it is a great masquerader. It can have many presentations. The possibility of fever and dyspnea raise the possibility of a segmental PT in a patient who is already having a malignancy, a suspected malignancy. But however, I am not suspecting a massive or a main pulmonary artery thrombus. So once the history is done, the possibilities that I am considering are the parenchymal disease in the form of ILDs or airway involvement in the form of endobronchial obstruction or growth, and pleural involvement as a less likely possibility of a pleural effusion, primarily mesothelioma. So from the examination, main important findings that we have are the inspection, trachea is deviated to the left and the movements are decreased on the left side, and trachea in the palpation these were confirmed and local fluids are also decreased. Important point to note here is there is no deep crowding, and percussion, most of the areas were impaired or dull, and auscultation also there were absent breath sounds in the mid and lower regions, and there is decreased vocal resonance in most of the areas. So from the examination we obviously know that left side is abnormal because of the reduced movements and the absent breath sounds. The possible morphology that we can expect because of reduced movements and breath sounds is either a lung collapse or because there are same side shift with reduced movements and absent breath sounds. First possibility that we should look for is a collapse, lung collapse, and more than effusion being considered because not a massive effusion, because if there is a massive effusion there has to be some contralateral shift, but it is the same side shift and there is no shift in nullness mentioned in the history. Because of absent breath sounds in the entire areas, just and dull note, possibility of lung collapse is more than effusion and unlikely to be consolidation mass or pleural effusion or a lung pleural fibrosis or a lung fibrosis. So after history and examination, these are the final possibilities that I am considering. So investigation part has not been discussed. Shall we have a discussion?
At the end of your historical diagnosis at a lengthy amount of multiple components of 4 anatomical and 5 substrates of discussion of anatomical origin, symptom analysis, we boil down to 1, 2, 3, what are your priorities of 1, 2, 3, then we'll go into the discussion before you unravel the investigations at this point of time.
So,
what is your first priority? And you excluded some things by some components of it. How best you use your clinical examination points with reference to 1, localization to the left of the. In the localization to the left, you made some comments with reference to 3 components of 1 is pneumonia, that is parenchymal component, 2 is pleural component, 3 is an obstructive component from inside to outside. Then you enlighten little with your available investigate clinical examination points. After arranging your priorities 1, 2, 3, what are the points? 1 for clinical, I am not talking about the rest of the used slides. Clinical, what you say, why it is not pneumonia. Clinical, why you say it is not pleural effusion or thickening. Clinical, how do you say it is a collapse of what type? If so, then we will go into that. In that is all what is called clinical entities. If you arrange your clinical diagnostic entities before investigations, 1 to the priority. If 1, 2, 3, priority wise.
So priority wise, I still go for a airway component in form of some endobronchial growth or obstruction. Because there is an loss of volume or shift of mediastinum and trachea to the left side, absent breath sounds, and decreased vocal resonance.
That is one.
Yes.
Next, please.
Next, in the form of sometimes mass with consolidation, mass with effusion can still have, but there will be no shift of mediastinum. That is one thing which is
your priority,
less.
first priority, last priority. If 1 or 2, only 1. What is the next? What evolves is an obstructive collapse. and a massive lesion, massive like the loss of lung volume on the left side. Total.
Yes.
Then, are their examination points are wrong or right? They said that the intercostal spaces are preserved.
Yes.
If they are, you assume that they are right, how do you explain it at the end? That's the question number one. Two, how do you excluded a pleural effusion?
Pleural effusion I not still exclude. It's on the lower side.
Yeah, that part it is second or third possibility.
Second. But it doesn't
What
fully
the third
explain the other
possibility at all?
symptoms.
No third possibility, only two. That's all. Left
Yes.
one prescription.
Yes. It's not a massive pleural effusion to start with. It can still be a mild to moderate. So
It is a primary diagnosis of pleural
primary of
effusion.
no pleural effusion, no, sir.
Not primary diagnosis.
Not primary
It is
diagnosis.
something else complicated.
Yes, yes.
Therefore, it is an extra bonus, if at all, but
Yes.
not a primary
Primary,
capital
not a
pleural
primary.
effusion.
Yes.
And third one, you like to put anything?
Third one, after seeing all the compartments and after the history, I don't have any other possibility apart from compartments. Like mediastinum and vascular are very unlikely to have this kind of
They
a
all excluded.
Yes.
One priority at the end, it's boiling down 1, 2 or 1, 2, 3. That's my
1, 2, sir.
One.
Probably 1, 2. Yes.
now. From first is your
Airway.
compressive component, obstructive thing. Second one is. Now you unravel the investigations. Then we'll go again back into the clinical discussions.
ECG showing sinus rhythm, X-ray.
This is a frontal chest radiograph. Trachea is deviated to left side. Only proximal part of bronchus can be well delineated. Rest of the bronchus could not be well delineated. There is the opacification noted in left enter hemithorax, obscuring the left dome of diaphragm and CP angle. And ipsilateral mediastinal shift is there. And left heart cardiac border could not be well delineated. Right lung field appears clear. Right dome of diaphragm and CP angle are well delineated. Features could consistency of left lung collapse.
Comment on the left diaphragm, indirect means from this X-ray, possible? Faculty? Then I will go to the discussion. Will you comment on the left diaphragm as is vice versa on seeing the plain X-ray chest?
No, absolutely, sir. No.
Vice versa, plain X-ray chest, direct or indirect comments from radiology.
It is not clearly made out, sir. The left CP angle and the left dome of diaphragm are wrong.
Not direct. Can you make any indirect comments?
I may be free inclined seeing this X-ray. This bubble shadows probably must have come up. I feel, but diaphragm is definitely silhouetted and CP angle is connected.
Therefore, you have to take into that indirect component which you are rightly pointed out. That is, the colonic gas shadow and the gastric bubble are still in that. You like to comment this with reference to your clinical science?
Just because the diaper is not being elicited on the left side.
That there is nothing like a tidal perfusion on the left.
Unless not be assessed or the
No,
entire.
no. Because there is no tidal perfusion in the lab, we are now banking on X-ray to retropolate your clinical findings and make a comment on the X-ray. That's my question.
May I add, sir?
Your question is, it is what type of collapse? The collapse is only radiologically many, but clinically only one. Clinically diagnosable collapse is a few, which you will comment later. Before that, you comment.
There is an
When you make a collapse radiologically, what do you mean by that?
If there is an underlying effusion, then it will
Loss
show
of lung volume.
Yes,
You
sir.
know?
obstruction of this.
That's all. You cannot comment anything on the collapses. Radiologically. Now, with reference to that, of your diagnosis are the primary component collapse, and this any light of correction, radio and clinico-radiological association of completeness or partialness. That's my question.
If you see here, there is an NMB cutoff which is seen. The air is not able to be seen distal to this, and possibly this is a complete left lung collapse.
Wonderful. Then
And then there is a right lung which is.
will you please comment on the upper 6 ribs of width and space if you make a comment of the left lung collapse? Or they are commensurate with your left lung collapse? The rib spaces and their inclination and angle?
Actually, if there is a chronic collapse, there should be a volume loss or a rib problem.
It should be subacute, it is not an acute. Therefore, still you expect anything or you don't expect anything.
The acute state takes some time.
2 months. Your diagnosis is confident for 2
Expectation must
months.
have.
My question is configuration of ribs of a total lung collapse is in line with this X-ray or against this line of X-ray. Simple. Okay, that's my question. Any comments from the faculty? Because he said clinically there is loss of lung volume. A loss of lung volume of an obstructive collapse have a specific radiological findings. You should make it. And when the options are done, you must explain why it is option. Is there any reason for that? That's my question. The question is, an obstructive collapse of an acute, as our discussant pointed out, may not have that many signs, and the signs slowly creep up. That's what loss of lung volume. But this is a 2.5 months of nearing 3 months of a quarter year, am I right? Then the angulation of the ribs is almost perfect in spaces, except a little lateral. This is a point not in favor of any collapse, because collapse will have like this. And the first third, second third, third third. The third third is linear. Middle third and medial third are equal. But here, middle third, medial third are equal, except a little regression on the lateral part. Normal obstructive collapse will have second, third become a linear component with the inacute angulation of less than 60 degrees. But the angulation is still preserved is about 90 degrees. That makes me, there is an obstructive phenomenon, that's a different, I don't know, which will come to across. At this point of an X-ray, you cannot make out an obstructive collapse because these two shadows are unlined and much below that. You must comment on the subdiaphragmatic air densities, these two are almost unlined and below. Normally also this is below. That makes me to think something commentation. You agree with it? Because if it is an obstructive total collapse, even forget about the ring. This shadow should be upgraded unless there is something else. Therefore, this should make you to put a query or something. It is not straightforward. It is not a red herring, but a red flag. And red herring, this is red herring to the clinical lab. And it will comment little after the things are over. It refers to some clinical findings which are narrated, which are already largely compliant. To comment.
Complete blood picture, hemoglobin is 15.7, total blood counts are 28,000, neutrophils 82, lymphocytes 12.
As a resident, comment and correlate. First is inference, 2 is analysis, 3 is connection.
Hemoglobin is elevated, so patient is smoker, so polycythemia.
Therefore, if he is a smoker of that magnitude, as evidenced by, and he had already a secondary systemic complication of polycythemia of that magnitude of 16 grams by 50% of hematocrit. That is not a small thing. You should expect many more things to comment. What is the other pulmonary component which happened with that hematological complication? A chronic smoker of that magnitude which resulted in secondary polycythemia denotes what is with reference to lung function. That is the question. There is nothing like a mumming up, keeping up. He is a resident. You should get the answer and ask me again and ask the discussant, am I right or wrong? If so, explain. I am not talking about that hematological component makes you physiological deduction from the lung body. That's my question. A smoker having a polycythemia of that magnitude, what it tells you about your lung function? That's my question. Simple. One, very good. Anything else? Obstructive airway is a chapter. I want the specificity of obstructed airway.
Emphysema.
One emphysema. Why it can't be chronic bronchitis? He has not asked the history prior to 2 months. Probably they are very fast in history, but not slow in their history narration. You are right, emphysema. Therefore, if the bronchitis subscribes or emphysema subscribes back to the X-ray. Now, comment on the right lung and the left lung, keeping in view of your emphysema at this point. See the lateral the emphysematous lung count for some change.
Compensatory hyperinflation on the opposite side. Right lung is hyperinflation.
Therefore, right lung is flat and the left lung much lower. On the basis of emphysema, something and anything can happen in the smoker, which our discussant is going to discuss little later. That is also great loss of more than 80% of treatment capacity when there is a reflection of 1/3 of hematocrit rise. That invariably cannot happen in bronchitis, which is a cyclical disease. Emphysema is a permanent disease. Now exclude all your mnemonic complications of inflammatory infections because of there is no CRP equivalent of ESR. As far as this, if there is infection, still it may be low, but there is no clinical symptoms of infection except fever after 2 months. And now it is 16 with normocytic. And normocytic anemia denotes it can still be a chronic infection disease of smoking.
Chloride is 1 or 2, calcium is 9, RF is, urea is 20, serum creatinine is 1, RBS is 127 mg per kg. LFTs are within normal limits. Total bilirubin is 1.1, direct is 0.4, indirect is 0.7, ALP is 75, SGOT 22, SGPT 24, total protein is 6.9, serum albumin is 4.1, LDH is 320. Sputum analysis, AFP is negative, CB-NAT, MTB is not detected, gram stain, no organisms detected, KOH negative.
Like to comment on this sputum analysis in this patient with your first diagnosis of obstructive collapse and second diagnosis of pleural pathology. With reference to the first diagnosis of obstructive collapse, any comments on this sputum analysis? If the sputum is a sample sputum of a disease site or the sputum is a non-disease side of normal side, why you guys comparate?
Usually, if there is a post-obstructive pneumonitis, this expectation of sputum is difficult from that side, and possibly this can, if I am thinking of a TB and if I am thinking of infection, this can be a non-representative sample still. It's malignancy and just sometimes endobronchial TB can still have an endobronchial inflammation. They can have positive sputum in that, which is primarily endobronchial TB.
But here, my question is, anatomically the sputum represents of your diseased lung or primarily non-diseased lung sputum?
Possibly, if I am suspecting collapse on the left side, this is sample from the right side. Possibly.
That's why that's an important point. A diseased component where the sputum is like this is originating from the left, not left disease, but in the right. Then comments on to the left. This type of sputum coming with real normal, what is your anatomical component of information on the sputum analysis with reference to the left diagnosis? Because it is a sample from the right lung, probably but not, because that's why it is everything is negative. This shows any amount of quantitative anatomical information of the left lung disease. Because your diagnosis is endobronchial obstructive component. That's why I asked you the question.
In terms of quantity,
Quantitative, not qualitative. Because the qualitative lesson is not.
in terms of quantity, there is an infection of bacilli or the amount of sputum that has produced also can be on the lower side.
Yes, KB thorax, 1 lakh. That's the quantity, but quantity they didn't mention. Only quality analysis. My common point is if it is not communicating from the left side and representative as per the analysis of the right lung of normal required sputum, which doesn't show, then the pathology is near total on the left. Nothing coming out. Or above more than 80% or something like that. That's why. That is a conventional retrospective analysis.
Go for a sputum in such a case because sometimes TB can still have right side involvement. Maybe that can
Because TB is a multilingual or multi-segmental involvement, it can come in. And TB never causes a totality of any lesion, neither pneumonia, nor pleura, nor lymph node. Big patching. Like the MBBS student passing every subject, 45 plus added by the university by 5 and given 5 like that.
INR 1.1, CRP 5.41, procalcitonin 1.5, viral markers are negative. Ultrasound chest, left minimal pleural effusion.
In the chest they made out pleural field, correct? Or angles are blunted, CP angles are blunted, probably pleural. But there is no probability in ECG, in PSA, ultrasound. You should take whether it is bleed or not. You made out minimal pleural field. What is your quantification of minimal in clinical sense?
Less than 500 ml, sir. Quantification, yes, sir.
What is that in clinical sense? Pleural effusion?
Mild, sir.
I don't know. Why I raised this question is clinical sense of minimal, moderate and massive pleural effusion and radiological sense of staging pleural effusion. There is nothing like mild, moderate, staging. Stage 1, stage 2, stage 3 or not convergent to the quantum of things. A little convergent, but not exact convergent. What they say is a minimal of 6 space, moderate of 4 spaces, and above 4 of maximum. Need not be. The best component of evaluation is ultrasound, in which you have to write the quantification, not qualification.
Yes.
You have written a qualification.
Yes, sir.
Minimal has no connotation in clinical sense.
X on abdomen and pelvis, grade 1 hepatomegaly with fatty changes, borderline splenomegaly. Tachycardia during study, no LV,
This is
RW.
supportive to the investigations of your differential diagnosis as a resident, what you can explain, and you will talk a little on this crystallization of 2D echo in this case. This platelet become as unlikely, that is, no clot infestations and pulmonary compromise. Be little, be a moderate extent. And now, you summarize that, sir. Explain 1, 2, 3, then little have questions to be clarified for the diagnosis. At this point of time, we already made our discussion. Dr. Vikram has come up with the Kramam of 1, that is orderliness of first as a obstructive collapse, complicated or uncomplicated obstructive clinical. Why? Therefore, I am giving you again. Is it an obstructive collapse uncomplicated or obstructive collapse complicated by either pneumonia or an effusion with this point at this level? Therefore, his first diagnosis is an obstructive collapse complicated by obstructive collapse, that means collapse consolidation little, with complication of secondary extrapulmonary complication of pleural effusion. Am I right? And the second one is at the end, you will still have some more things.
one thing for the consideration of the right safety but there's one submission there. Usually we take
No submission. You can authoritatively release the bulletin.
usually take more than 55 into the policy for the 950, but this for a suspected endometrial obstruction in a COPD in a chronic smoker, HB is relatively on the higher side. If your suspected malignancy should be relatively lower or 11, 12, but this patient possibly has 15 because of the smoking.
Malignancy, in what way changes the hematocrit in an obstructive disease?
Chronicity. Usually malignancy can have non-chromic compensating anemia.
Malignancy has nothing to do with the hematocrit unless it is a paraneoplastic hematological abnormality.
Everything is the borderline splenomegaly and hepatomegaly. This weight is 79 and the BMI is 28. Possibly some non-alcoholic fatty liver disease, possibly going
Is alcoholic?
non-alcoholic.
Right, non-diabetic? Very good. Now, You have made it that it is our discussion and in a disciplined, punctual fashion and perfectionary dissection, made out the first diagnosis as an obstructive collapse, not simply a collapse, but it is chronic and complicated by a pulmonary component of probable pneumonia and an extrapulmonary component of an effusion. What is that clinical sign which they narrated tells you that it is not a pure obstructive collapse, uncomplicated. Which is narrated, which are pointed out to make you a comment.
In terms of X-ray,
In terms of clinical, I'm more of a clinical idiot.
in terms of no recrowding, that can
Yeah. That point should be taken into at this point of cognizance. A collapse of 3 months duration, unless complicated, cannot have a risk being normal, either radiologically or clinically. The options of the crowding tells you whatever the collapse is, total or otherwise, still it is complicated by 1, 2 or 3. That's what we talk about. Therefore, the second possibility we still kept is no.
primarily pleural
Can it be a malignant pleural effusion for the entire thing? Like
unmade.
why? Because there is no recrowding. That I think that is a smoker, malignant mesothelioma, I may think at this point. What makes you to say that is least likely or unlikely?
There is no
Clinical.
typically there is no contradiction. Simply there is a massive effusion. There should be contradiction and extension. Second, there is no recrowding. If it is a chronic effusion, there should be some recrowding and
That is loss of movements and flattening and all this. That's option. Therefore, there is a distancing pathology in spite of destruction. A destruction with a collapsing pathology, destruction with a distending pathology. This is more likely a distending pathology of destruction rather than a destruction with regressive. That is evident by non-recrowding and chronicity still preserved. Now, what investigations we like to want at this point of time as a pulmonologist himself?
I'll go for a CCT thorax and
You want to go for a simple CT or HRCT or a contrast CT?
contrast. Contrast in CT to cover liver and adrenals also because I'm thinking of positive malignancy.
Because of malignancy, you like to have a contrast CT. Suppose this guy had a renal function, how is it? Is abnormal renal function, stage 3 renal failure. And going for is a nephrologist stage 4 says. No, sir, for the sake of academic discussion, I am saying this is a stage 3 by 4 renal failure. And that's why you like to go for normal CT, HRCT, contrast CT. Or normal and HRCT, that means same. No. When you write a pulmonary, they will do HRCT, no normal CT.
Maybe NCT and HRCT are both different, sir. HRCT is perhaps 0.5 to 1.5.
No, that is. But when it comes from a pen of a pulmonologist,
HRCT.
they always say normal CT is a synonymous with the pulmonology as HRCT. Because
Whereas
they
it
go.
is both different, sir.
I am not talking about difference with reference to the expression. They are different because that is a thick cut. This is a very small slice cut. Will it give any further information? Suppose it is unfit. You do for a simple CT or HRCT. HRCT going to give more information than this. In this case,
Not only thing
Now,
that
what
we
is the
can see
radiation
that
difference between HRCT and simple CT? In chest, is it same radiation or differential radiation? Time frame.
For
HRCT versus simple CT. Time frame and radiation frame. Talk. Similar or dissimilar?
dissimilar.
In this case, our discussion says HRCT doesn't score our simple CT. If at all anything scores, it is contrast CT. If that fellow is unfit for contrast CT, what is your next line of investigation?
in terms of two cases. If he is oliguric requiring dialysis requiring kind of a RSP or non-oliguric.
He is unfit, partially, totally unfit, then what is your choice? Partially fit, what is your choice?
Partially fit, I would still go for CCT thorax.
CCT with?
Thorax and
No, thorax with. You have to suggest, he wants a CCT contrast and he is not completely unfit and it is given partially fit. Then how do you proceed for the contrast media?
We generally cover up to the adrenals, sir. When we are suspecting
You reduce the volume or change the media?
water soluble contrast, low
Volume? You make it faster and a reduction of volume. Yes, sir. Now you want to CRCT. Anything more you need?
It's done, then I will decide on further tissue biopsy.
Second investigation is bronchoscopy.
Biopsy either by
No. Is it bronchoscopy or biopsy?
that I'll see from the CT scan. I'll decide on the CT. If it is a peripheral lesion, if there is a mass that we are leaking, if it is a non-invasive test, we can go for a biopsy.
Now the question is, he is not affordable to a CACT or anything. That case is your God, bath. You like to proceed, there is no, when the CT is not available, bronchoscopy is not available. Then what is your line of approach? You need to have a confirmation.
You can see on the ultrasound there is any possible mass which is being.
In the ultrasound, they are given a minimal effusion. I
We
have given
will ask them to look for a mass. Preferably there is anything visible.
Therefore, you want to have an ultrasound guided aspiration or ultrasound guided biopsy, aspirational biopsy. Two things. One is aspiration of fluid, two is aspiration of the mass, three is biopsy.
Biopsy, preferably because young male suspected malignancy can give issues for mutation studies also. We have biopsy.
Therefore, that is the second purpose. Basing on the CT, you will change whether it is a transthoracic biopsy or something else. Right. Therefore, CT tells something. Do you arrange your investigations in line of your sensitivity and specificity of confirmation in these three? One is CSND, two is bronchoscopy, two is transthoracic aspiration or biopsy, three is bronchoscopy. Which you like to say definitely confirms your diagnosis.
Definite confirmation is the biopsy.
Whatever you do.
Definite confirmation of the malignancy of the type cell. We don't want a malignancy type, we want a morphology.
No, biopsy of any root or only specific root. That's my question. Your diagnosis is an upset to collapse.
Transthoracic procedures have a high sensitivity or high diagnostic of more than 90%. Bronchoscopy, yes. Biopsies are high, have a high.
The chances of getting a lesion in bronchoscopy makes 100%, but the chances of not getting a lesion, 50% makes 100% loss of the tissue, like a transthoracic.
Modified this. Not only flexible bronchoscopy. I not only do a flexible bronchoscopy, if there is no endobronchial growth, I can do an endobronchial ultrasound. See what
You want us. Yeah. That specifically make it done. Therefore, there are three stages of your investigation, which is that our esteemed discussant has diligently discussed and ultimately dissected out, pointed out two even diagnostic possibilities. For the sake of it, it's an upset to collapse, complicated, both extrapulmonary and pulmonary. Two, possibly, still a pleural pathology, as our doubt. And your choice of investigations are contrast enhanced CT, followed by ultrasound guided aspiration, cytology, or a biopsy, and CT determines to go to endobronchial component. And if it is not feasible to attain, he wants to dissect it out by endobronchial ultrasound. Now, comments from the head of the department and discuss moderator at this point of time. You are agreed to this discussion, or you want to add, or you want to say, this is my preference of 1, 2, 3 rather than 1, 3, 2.
Next slide is contrast CT, sir. Contrast CT. Whether we have to see whether there is endobronchial or external obstruction and any other pathology, we have to confirm by contrast CT before going for a biopsy. Either way, CT guided or a bronchoscopic guided biopsy. We have to see first localize the lesion. Is the intraluminal
the lesion
cutoff?
is localized clinically. Don't say the lesion is localized clinically, then only we have gone to it. The lesion is localized clinically, dogmatically, and dictatorially. That is a left thoracic abnormality comprising probably intra-obstructive component complicated by clinical examination and supported by ultrasound to that extent. Therefore, there is no worry about localization. The query is localized as a masquerading other lesions or not. That's the query. Asymptomatic.
I want the discussant to elaborate why this patient is very short history of 36 years age. Why you are preferring malignant more than a benign lesion here?
Why you are preferring a malignant obstruction at this point of time? Then you answer that question. What are the other non-malignant possibilities? I will ask you that question.
Young male, because he's a smoker and smoking of 360 and still consuming possible malignancy.
What is the long duration of his smoking?
18 years. 18 years.
Have you mentioned how many packs of years?
20 pack years. 20 pack years.
What is the clinical connotation of taking a malignancy into consideration of different malignancies? What is the minimum of pack years is required? No. If there is any pathologist here?
One thing I can say from what the cancer guidelines, cancer screening guidelines suggest is smoking is more than 400 or pack is more than 20, we can start screening for lung cancer.
That itself is one of the guidelines.
That is what there is one.
No. Here there is that. That's why he has put it diagnosis rather than the other way around. I'm not talking about. In spite of his smoking is less than that, the possible that is negative positive inference. This is a positive inference. Positivity is inference is he smoked more than so many years of 400. And positivity that it is first possibility most likely irrespective of age is a malignancy. That is correct. Now he is not a smoker. What is likely to add in this case?
He is not a smoker. He would have considered a benign disease, but still a malignancy because in terms of frequency of endobronchial obstruction, we commonly see never smokers.
Now, what endobronchial disease of a benign nature can be complicated with effusion?
The effusion can be secondary to passive collapse and rather than
Wonderful. Therefore, you say it is an endobronchial benign lesion causing an obstructive pneumonia and effusion. Am I right?
that effusions can still be mild rather than moderate or large.
While raising this question, an endobronchial lesion, what are the possible endobronchial lesion non-smoker at this age? That's right.
Benign
Benign aduthuna endobronchial.
lipomas.
Your side. What is the commonest non-malignant endobronchial tumor which will be treated by you as some other disease for a long time? Asthma. Carcinoid. The other one is benign. But the point is, any benign lesions which you said, like myological or lipomatosis or something else, they are rarely going to be pleural complications unless you mediate transbronchially or extrabronchially. Therefore, pleural effusion in this case, even if it is an endobronchial benign lesion, is least likely, except the endobronchial component is infectious, parabronchial, tubercular lymphnodal masses with ulceration, and then parenchyma. Other than that, no benign is least likely to have an effusion. The effusion, bacterial cells of 400 and odd, he has made a first possibility of malignancy. In spite of that, there is correlated positive inclination.
The normal state of stopping after 5 years after stoppage. So immediately once you stop is not. So if you stop for smoking after 5 years, you will come to the stage where a person was
Near normal. But this cannot be with reference to the malignant potential. The question is for the resident. A smoker of 25 years stopped smoking. Can he get a malignancy at the end of 25 years? Can he get it before 25, between 10 and 15? What is the possibility? Still you entertain or don't entertain? Okay, simple question.
These are axial sections of lung showing mediastinal window and lung window. Here in this we can appreciate a soft tissue density lesion present in the left main bronchus. This is causing occlusion of the bronchus. There is also collapse of the left lung with mild hyperventilate right lung. These are the coronal sections. This same patient showing lung window and the mediastinal window. Here we can see the soft tissue density lesion causing occlusion of the left main bronchus and also complete collapse of the left lung with mild crowding of the ribs and also mild hyperinflation of the contralateral lung. And there is also mediastinal shift towards left side.
Here diaphragm can be seen in CT. If you don't say the diaphragm is not in CT, then I will be a little taken aback. Can you or cannot? Diaphragm. Now where is the diaphragm? Show me.
So it's lower.
Is it in normal position or above position for a complete collapse? Then what I am interested in. Therefore, that shows it is not simply an obstructive collapse. Comments at this point, an obstructive collapse, how is complicated to give this picture of diaphragmatic as well as CT component?
You can suspect a mass actually, but this is a non-contrast where I am not able to see.
No, forget about the contrast at this point. I am not talking about the
It could be associated mass which is not letting the lung collapse. That's one possibility, but still we are not seeing
from
any.
inside out. Is the mass extended to outside and making, or mass extended outside to inside to making? Which you prefer?
Inside to out, from the lung to outside. That's what.
Not outside to inside. The mass is occupating outside like a pleural effusion, and but it is expanding. In the same way, the expansion is responsible for the involvement of the left main bronchus. Which you prefer with this picture and a clinical picture?
It must be coming from inside to out, rather than from out to inside. Because if it is starting from the chest wall or from the patients should start with chest pain or predominantly chest pain, but this patient had dry cough to start with. So I would still go with a parenchymal mass which is encroaching into the airway and possibly.
Therefore, it is a primary bronchial endobronchial lesion spreading out to out. And now there is an effusion. We like to comment that effusion where we are infiltrating abrasive effusion. And for this case, and this concern at this point. Any comment if this effusion is abrasive or a simple symptomatic effusion? Because it is CT and it can have to make it. Can you make it or not? A CT, unfold. Unfold downstairs.
Higher side, but here I am not able to see any infusions.
Yeah, that's why such a massive amount of the solid lesion is coming from bronchus to outside, or that is coming inside to the bronchus. That's my question. Why a primary bronchial lesion eroding outside equally erodes inside? Then you should have a hemoptysis at a point of time. But when it is coming outside the area, hemoptysis may not, because it's choked to completion. And this is massively expanded. Apparently, it appears to be a clinical collapse. But when you diligently search, there is no collapse and the crowding is not there. And the tracheal shift is gross in the upper part, but medial shift is not that much. That is important. Now, your comments. Therefore, the ball is in your court. Now you read it. She finished your reading. Anything more? Comment on the rib case.
Post contrast, the lesion is showing mild enhancement compared to the pre-contrast image.
I am interested in only ribs of reconstructed nature, where the lesion is entering into the rib. That's one part. Clinically, there is no pain. Still, there can be rib involved.
Probably this is the vessels. The mass is probably here. Not able to differentiate. This is what I feel is the mass coming inside. We cannot still see effusion clearly here.
We are not able to differentiate any bronchial component at all, despite of it being mass.
There is no
Any concern? Anything more you like to do? Any classification? Any classifications? Report, madam. This is now you can make a review of bookings with this. What do you patient expect to be this case when you draw the fluid? Mindly, I can write ultrasound guidance. What you appears to be? Have you done it?
So we cannot attempt in this kind of case.
You don't attempt because your diagnosis is malignant.
No, sir.
Or
Possibility of puncture in the lung are high in such a mild.
You no. Mild effusion, the already diagnosis in the lung is collapsed and the mass. The chances of your aspiration getting a malignant cells is more rather than puncturing the lung. We use it to do transthoracic at this point because the lung is already collapsed, no air entry, and you had a massive amount of mass and a less amount of pleural effusion. That's why the shedding into the pleural effusion is very high yield. Even 1 drop you get it.
Sometimes it is opposite reason. Sometimes we don't get a effusion.
Now explain this. I raised the question for the pertinent observation and explanation. Why do you don't get much amount of yield in the pleural effusion when a big mass? When a pleural effusion is less and a big and mass is less, the yield of malignancy in the pleural tract.
Basically, chances of malignant effusion are high and it is a moderate to large. Possibly that suggests that it is a pleural mass which are generating or which is causing the effusion to come.
Whereas in a large mass, it is the vascular component which is responsible for effusion, unless there is a transgression in the form of. If it is hemorrhagic, I will definitely get an E. But non-hemorrhagic, it is a vascular compromise of both the hepatic as well as venous, the secondary obstruction. That's why if you tap effusion, you know the mass is pass or the it doesn't matter. It uses a 7 and see it like this. And you can also feel that whether the diffuse and separating adenocarcinoma or not. Specific acid test. How is the pulmonary?
Shift towards left.
Because shifting the gross word contains many things, which is responsible for more symptoms. Not right. Can't be very vague and generalized in your expression of ability to investigate. Thank you. That there is a component of shift of vascular component.
The airways distance to this obstruction are not visualized. There is no evidence of cysts, fatty component, calcifications, cavitation and necrosis within the lesion. This lesion is showing mild enhancement on post-contrast study. There is evidence of complete collapse of left lung with evidence
What is the inference of mean outspeed is 50 and mild enhancement with reference to pathological interpretation? It is mildly enhanced. What does it mean to you? It is a mass mildly enhanced. That should some bells to the pathologist as well as clinician. That is not highly vascular. And number 2, any comments? Mean house speeds is 50. Why you mentioned that? Is there any significance?
Difference between the pre-contrast and post-contrast, sir. The difference.
That is the difference. The lesion is showing mild enhancement and the contrast component. Enhancement without contrast. Why you mentioned 50? That's my question. Comments?
Compared to the pre-contrast and post-contrast, we generally measure the HU difference, sir. More than 15 or 20, we consider more towards malignancy. So that's why I mentioned pre-contrast and post-contrast.
It is not below 30 or 20 like that, and it is nearing above 50. It is less, more likely in spite of the enhancement or non-enhancement, it is leaning towards the malignant side. Agree to sir? That's what I want.
That's it.
Oh.
Mildly
We want the PET at this point, we want the first information of biopsy. You have to put the biopsy first, not the PET. That is meant for making grading, objective, what is called subjective grading. Objective grading, subjective to objective, but not diagnostic.
Bronchoscopy was done.
Now the case is closed. That the diagnosis by the diligent Trivikram, Vikram, not 3, but he has made 3 points as Trivikram. That is, it is endobronchial, near normal total obstruction complicated by pneumonitis, complicated by effusion, most likely malignant, and it is nearly confirmed by your ultrasound as well as CT contrast enhancement. Staging is also done. It is a lateral extension to the right lung of the lymph node, which makes it with a 3 AY or something like that, about 3 something. You were not staging. No. And he wanted first an endobronchial component, bronchoscopy followed biopsy, not a PET scan at this point of time. Now supply and make us happy, and he will be perfectly happy. He has excluded before. You know on the investigation, he excluded every pleural pathology because you still had a 10% of flora, not the foam. What is the time? How much is occlusion? You are able to pass beyond that or stop at the tumor.
Stop.
At what level of the bronchus? Have you mentioned?
Left.
Left bronchus is you are able to enter the left bronchus or not?
So left main bronchus.
Therefore, you are at the act. Bifurcation itself stopped.
Left main bronchus.
I am asking that it is an absolute collapse. Obstructive absolute, 90%. Then expect all the shifting, but not there. That is one of the clinical obstructive expanding.
Vocal cords are mobile, carina is acute in angle, right upper middle lower bronchus are normal in anatomy, irregular polypoid growth seen arising from the medial wall of left main bronchus, occluding the lumen. Wall fluid analysis, cell count is right side 5 cells, left side is 190 cells. Left side sediment smears examined show power.
Any slide, right comment? First comment from the pathology.
This is a low power image of the microscope which is showing a tumor cells which are arranged in the form of a glandular pattern, and this is the high power image which is showing a tumor cells with hyperchromatic nucleus and increased ratio. Based on this, we have diagnosed it as adenocarcinoma.
Bronchial epithelial cells with tumor diathesis, mild pleomorphism, hyperchromatic nuclei, moderate cytoplasm, increased NH to C ratio. Background shows dense inflammatory cells and focal necrosis. Impression suggests probably adenocarcinoma. Endobronchial biopsy.
In high power, showing tumor cells are arranged in glandular. Tumor cells are arranged in glandular pattern. Scattered distinctly. The cells are showing pleomorphic hyperchromatic nuclei with moderate eosinophilic cytoplasm. This is the IHC of the same patient showing EMA positivity. So it concluded as a adenocarcinoma of the lung.
What state it is? I don't know.
Epithelial membrane antigen.
EMI.
Cytokeratin positive in adenocarcinoma and also squamous cell carcinoma. Squamous cell carcinoma, cytokeratin 7 will be positive. 5 of
Right? At the end of the day, over, let's scan any component, stays with.
mildly avid ill-defined heterogeneously enhanced soft tissue density seen involving left main bronchus measuring.
I'm interested in PESCAR. The mass cannot be delineated in what is the contrastivity or otherwise, but they can be delineated because the uptake of electrode as well as some malignant tissue is different with the M4 kg or something. Or little change. Which is already evident use. Temporals, not therefore these can't be detected underlying the primary abuse. Therefore that's done. Understand. Okay. Now what you have done? What you want to do for this case? You want to go for anything?
Stage 3.
You want to further tissue tapping or gene tapping or therefore chemotherapy? Yeah. And that is genetic study I'm talking about. Gene. Which mutation is strongly unlikely to respond in adenocarcinoma? Which is likely to have a powerful response to this chemo as well as biologics. Thank you. Wonderful.